So I'm next. For those of you, I think most of you were here yesterday, but for those of you that weren't, I'm Ben Berkman. I'm a faculty member at the NIH Department of Bioethics, and I work also in the NHGRI, the Genome Institute. And yesterday I gave you an overview of some of the big ethical issues that I think are of pressing need for discussion in the genomic research space. But today we're going to focus in on what I think is the big one, and the one that's been maybe the most controversial, and it's the right not to know. And I'm going to make some controversial claims. Again, I'm a federal employee, so nothing that I say represents anything that the government actually thinks. So yesterday I showed you this slide. Sequencing costs are coming down. We've got this problem of incidental findings where you find something because you're generating so much data, you're finding things that are beyond the scope of your research question that but could have clinical impact on your subjects, and that raises all sorts of questions. And the big one is the right not to know. If you find one of these things, should people be allowed to say, you know what, I don't want to know that. That's not why I'm here. That's not important to me. Or because they're so important, should we have a policy in place where people do need to know these things? So let me start with a case just to frame this. P is having her genome sequenced, and during the informed consent process opts not to receive any secondary results. During their analysis, her physicians or the research team, as this can happen in the clinical or the research space, but we'll focus on the research space here. Her research team finds evidence of high genetic risk for hereditary non-polyp-forming colon cancer. They believe this information will prevent serious disease and perhaps even save her life. This is not the kind of colon cancer that's caught with normal screening, but there's enhanced screening that you can catch it early and it can be cured. And so the question, she checked no. She said, I don't want to know this, or I don't want to know incidental findings. Whether she knew she was saying no to this, we'll talk about. But should they disclose the finding even though the subject indicated that she did not want to receive any secondary findings? Let's just get a show of hands. Who thinks that they should not disclose it to her because she said she didn't want to know? All right, and who thinks they should disclose it to her even though she said she didn't want to know? Well, we'll get into that. The obvious challenge is you should have a discussion. Although we're not going to discuss the case. This is going to be more of a lecture, but having a discussion is hard. How do you call someone up that said they didn't want to know and say, oh, hey, yeah, by the way, we found something that you said you didn't want to know. Would you like to know it? And how do you have that discussion without revealing that there's something out there? And there's a good bit of evidence that once you tell someone that there's information about them that they don't know that someone else knows, they need to know it. And so you sort of undermined their choice not to know by telling them that there's something out there. So it's right, you should have a conversation. I'm just arguing that it's maybe not the solution to this problem. So you see the, yeah. We will get to that. Yes, the answer is fix the informed consent process. The problem is that this is what all the informed consent forms look like. They all have a binary choice. Do you want to know yes, no, and people check it. That's just the practice right now. So my big questions here, I want to ask about whether the traditional conceptions of the right not to know are appropriate now that we're in a genomic era. I want to ask whether there are any perhaps limited circumstances where it might be ethically appropriate to override someone's expressed wish not to know genetic information about themselves. And I want to think about how the right not to know should be reflected in informed consent and return of results policies. And so just to put my cards on the table, I'm going to defend the idea that we should abandon the notion of an absolute or strong right not to know. And provide an extended argument in favor of setting a default for returning high-value information without asking about a preference, whether they want to know or not, or they don't want to know. And high-value information here I'm defining as conditions where medical action can mitigate or prevent mortality or serious morbidity, where there's strong evidence of the link between the genotype and a significant disease risk. So I'm setting the bar pretty high. And we're not talking about things like Huntington's, where there's nothing you can do, and we're not talking about sort of low incremental increased probability of common diseases. We're talking about sort of the big ticket items. I'll give you some background. I've got a number of arguments, some of which I might have to go through a little bit quickly, and then I'll give you my conclusions. So, Act 1, early views. So we've been talking about incidental findings for the past decade, and this was the easy one. This was one that everyone agreed that findings should only be returned when they're desired by research participants. A question came up yesterday that I alluded to this, but the obligation isn't to force it on people, it's to offer it to people, and then they can pick whether or not they want it. And this implies a requirement to solicit subject preferences and ask whether or not they want, during the informed consent process, you ask them whether or not they want to know. And so people spoke about this pretty forcefully. Results should be offered to participants, not foisted on them. There was an NHLBI working group where they talked about this notion of how strong the right not to know should be, but ultimately they recommended to always honor stated preferences. That was in 2010. And there are various legal instruments internationally that sort of codify this idea that people have a right not to know. And then into the breach came the American College of Medical Genetics and Genomics that released recommendations about incidental findings, and they articulated a minimum list of 56, it's now 59, results that should be actively sought by the laboratory. Now, they limited themselves to the clinical space, but predictably, this was immediately imported into the research world as well. And they called this opportunistic screening. We've got someone in front of us, we have data about them. It's not that hard to do an analysis for these 56, 59 genes. Just look for them as a matter of course. And notably, they argued against soliciting patient preferences about receiving incidental findings, but making a fiduciary duty argument that clinicians have an obligation to warn patients about high-risk variants where an intervention is available. So that was, they sort of dropped that as a first trial balloon in this area, and the response was quick and vigorous is one word, angry is another. Every meeting I went to for a couple of years after this, all the genetics and research ethics meetings I went to, always devolved into a sometimes quite heated argument about this issue. My favorite is the ACMG recommendations on incidental findings are flawed scientifically and ethically. What do you really think? So the reaction really was pretty universally against, almost universally against the recommendations. There was very strong disagreement. Choice matters. Patients may wish to decline additional analysis on a number of grounds. Concepts of shared decision-making and respect for patient preferences argue for offering meaningful choices whenever possible with appropriate informed consent. I'm not going to read all of these, but it was really quite strong, the pushback. And it caused the ACMG to walk it back. They surveyed their membership, and they said that there was consensus among ACMG members that patients should have an opportunity to opt out, so they updated their recommendation and basically walked back the right not to know claim that they had made. There are a number of arguments you can make in favor of the right not to know. The biggest one, obviously, is autonomy. We value autonomy, sometimes above all other principles, and so we should have respect for patient preferences, and there's a right to refuse medical interventions, including a legal right to refuse medical interventions. I'll talk about that in a minute. People worried about coercion, they worried about inadequate evidence, that the evidence of these, forcing people to receive information that we weren't there yet because the evidence wasn't strong enough to justify the actual medical value of some of these findings. And so it was in this context that I started thinking about this issue, and it didn't seem right to me that everyone was in agreement and was in such strong agreement that there's this absolute right not to know, and I thought that can't be the case. And so I started thinking about how I could defend something less than an absolute right not to know. And so the first step was going back to the philosophical literature. This concept is only about 20 years old. In the late 1990s, people started writing about the right not to know. But my worry was that the contemporary right not to know advocates were presenting their views in the absence of any sort of historical perspective. They were arguing that the right not to know is just sort of self-evident. Duh, this is just the way the world is. But if you go back to the philosophical literature that originated this concept, there's surprisingly limited support for the right not to know. There are a handful of people that argue for a strong, absolute right not to know, but most people argue for a limited right not to know, and there's a sizable group of people who argue against the notion of a right not to know altogether. The people that do argue in favor of a right not to know generally ground their argument in autonomy. They raise concerns, obviously, about paternalism and scientific uncertainty. The people who argue in favor of a qualified right not to know, they challenge the notion that this is about autonomy. They say things like misunderstanding about the nature and moral force of autonomy have led some in the genetics community to a false conclusion about genetic ignorance. And they say and this is important, I think, when you label something as a right, it gives it a sort of undue value or power. And so we need to be careful about calling things rights, because it serves as sort of a trump card when you are having an argument about someone and will say, well, I have a right. That's sort of, there's no counter to that, because it elevates the discussion to a level where you can't argue against that. And they think that autonomy fails here as a valid principle because there's no such thing as unfettered choice. We're constantly making non-ideal choices, and there's no basis for the idea that information alone is autonomy constraining. So no one is saying that these people have to go seek treatment. They're just saying we need to give them a piece of information, and then they can make their autonomous choice. And autonomy isn't boundless. There are lots of ways in which our autonomy is constrained as a matter of public policy. One philosopher in particular leaned on this idea of building on spatial privacy. He talked about the psychological spatial privacy, that we have a right to sort of protect our views of ourselves, but he notably, this is probably the most articulate about the right not to know, but he said it's not an absolute right. It's to be weighed with other compelling interests, and specifically argues should be given prima facie respect, which should be accorded unless due cause for disclosure can be shown. And the case he articulates 20 years ago is basically the case we have now, where we've got availability of a cure and severity of condition and likelihood of onset. When you've got really important information, it doesn't matter if you want to maintain your psychological integrity. These are the kinds of things we should return as a matter of course. And then again, I said there were people who argued against the right not to know altogether. Some had the incoherence objection. They said it is nonsensical to talk about autonomy when you're depriving people of information. In order to make good decisions, you have to have good information. And so invoking the right not to know is actually autonomy defeating, because you can't make good decisions. And then there's the third-party harms argument that genetics is something that affects not just yourself, your family as well. And so refusing to learn information about yourself is actually also has the potential to harm other people. So, and then the third argument here against the right not to know altogether is the idea that when people say there's a right not to know and we should be super strong, they always cite to 3 case examples: Huntington's, Alzheimer's, and breast cancer. And I would argue that Huntington's and Alzheimer's, at least, are the wrong examples, because there's things you can't really do. I mean, Alzheimer's is changing, I acknowledge, but these aren't generally things that you can do something about. And so I think the better frame is to ask whether there's an absolute right not to know that includes the ability to refuse information about conditions where medical action can mitigate or prevent mortality or serious morbidity, where there's a strong evidence of link between genotype and significant disease. BRCA is a little bit harder, but I think we are moving towards a world where people might get regularly tested for BRCA, and so there's a complicated argument here that I don't have time for. The bottom line, though, is that contrary to what contemporary commentators have been arguing, the notion of a strong autonomy-based right not to know sort of rests on an unstable conceptual basis, and really only a couple of philosophers have endorsed such a position, and the majority either say it's a qualified right or it's not even a valid concept altogether. So, the right not to know, I argue, is philosophically shaky. Now the question is whether there's this legal right not to know. Pro-right not to know commentators argue that the very clearly established legal right to refuse medical treatment also implies a right to refuse learning about medical information. I think on its surface that argument has some appeal, but I think when you dig in, it falls apart, because there's no actual case law that establishes a right not to know. The right to refuse treatment cases are about physical interventions, and the judicial decisions are hinged on the notion of bodily integrity. We don't want people doing things to our body against our will, injecting us or examining us or cutting us. Building on jurisprudence from the common law ideas of battery, unwanted, offensive touching. They don't mention psychological integrity. Psychological integrity, I think, is a separate concept from physical integrity. And so I don't think that the relevant case law clearly demonstrates that the right to refuse medical treatment is specifically rooted in the idea of an individual's autonomous right to bodily integrity. I think this would be a case of first impression. And it's perfectly plausible that courts might say, yes, there's a right to refuse medical treatment, and there's a right to refuse medical information. But I think that it's a stretch to argue that existing jurisprudence automatically implies a right not to know. And I think if you look at the way the courts have treated mandatory provision of information, you can make a pretty strong case that the courts aren't that shy about forcing people to get information. These are three examples here: abortion, the laws requiring women to receive certain information about their fetus even if they don't want it, toxic torts, and the duty to warn cases, both in the context of genetics and HIV. These are all cases where courts have been perfectly comfortable saying, you know what, you have to learn this information even if you don't want it. And so I think it's unlikely that the courts would find that there is a legal right not to know. So, philosophically shaky. I think the legal right not to know arguments fall apart. Then what are my arguments? My arguments against the right not to know. And there's really going to be an interlocking series of a few. First, I'm going to talk about the idea that people's views on the right not to know, I think, are less strong than we think. I'm going to make a comprehensive analysis of the harms and benefits that result from adhering to a strong right not to know position. And then I'm going to talk about moral distress and genetic exceptionalism as two more things that weigh in favor of something less than an absolute right not to know. So the identified life effect, this is the idea. Well, let me start. I'm going to show you some data in a second. The first question I asked people was, do research participants have a right not to know their own genetic information? In other words, would it be acceptable for them to choose not to receive any genetic incidental findings? I'm not going to ask you this because I've already sort of tipped my hand here, but if I had asked this question at the outset, I'm almost certain that 90+% of you would have raised your hand. But I did ask you this case, or a version of this case at the beginning, and it was split about 50-50. And so I think when you move from sort of the generic question, do people have a right not to know? Of course, we love rights. We love rights to control, the ability to control our own information and space. So people generally endorse this, but then when you ask them, well, does she have a right not to know this because she might die if she doesn't know it? The people's views change. And so here's some data. When we asked them those two questions, the baseline was 79% said definitely she's got a right not to know, 17% said probably, so that's 96% that said there is a right not to know. But when you asked about the specific case, that dropped to 63%. And then the people that said there isn't a right not to know, when you asked the generic question, there were only 2% that said that, but when you gave them the case, the specific case, that jumped to 26. The number of people that were just like, I don't understand I'm not sure what's going on, went from 1 to 11%. Maybe it was my survey questions. But so I think this is interesting. So at the end of the day, when you ask them about the colon cancer case, 63% of the people still said, don't tell her, she checked the no box. If she dies, she dies. She made her autonomous choice. So that's still a majority of people, but that move from 96 to 63, that's a big jump. And so I think that argues that the absolute right not to know makes sense in abstract cases, but once you present to people with specific cases, specific pieces of life-saving information, it changes the way people think. And I think this suggests that people's views on the right not to know are softer than they realize. I also think, and this gets to a question earlier, that responses to binary checkboxes on consent forms differ radically from responses to conversations about an actual concrete example. To the extent that it's the practice now that people are just saying, do you want to know incidental findings, check 1, yes, no, I think that's a terrible policy, and I don't think it's accurately capturing people's actual preferences. So the argument here is that people's views on the right not to know are softer, maybe, than they initially seem. So now let me engage in sort of a comprehensive analysis of the risks and benefits. And the question here really is, when should psychosocial concerns get to trump the prospect of life-saving intervention? And I think that the focus on autonomy-based right not to know has had an unfortunate effect of short-circuiting the discussion of the topic. We focused on the harms of giving something to someone against their will. But I think in order to have a conversation about this, you need to focus on the harms of giving something to someone against their wishes, but also on the benefits of honoring or ignoring the right not to know. And you're gonna make, if you'd only remember one thing about this talk, you're gonna make one of two mistakes. You're gonna make a mistake. You're either going to give someone something that they didn't want, or you're gonna lose an opportunity for medical intervention. You can't have it both ways. And so I think you need to, instead of just focusing on the former, I think you need to focus on the pros and cons of both. And whether you agree with me or disagree with me at the end, that isn't really the important thing, but you need to have this full examination of the trade-offs. And so I think there are 3 questions you need to answer in order to have a full examination of the trade-offs. How many people really wouldn't want to know genetic information about themselves that could have a profound impact on morbidity or mortality? Of those people that wouldn't want to know if they were given information against their will, what's the actual harm, the magnitude of the actual harm that they would experience? And then on the other side of the equation, how many people, if you do ask people whether or not they want to know, how many would erroneously or accidentally not receive potentially life-saving information if we're actively soliciting patient preferences? So the first question, how many people wouldn't want to know? It's a tiny number. In some studies, 96, 98% of people, if you ask them, would you want to know genetic risk information that would have a direct impact on your health? Huge numbers. You never see 96, 98% in surveys. So it's a tiny group of people that really wouldn't want to know this kind of information that I'm talking about. Remember, I've defined it as high-value information. We're not talking about Huntington's here. We're not talking about, oh, you have a 10% increased risk of developing heart disease. So it's a tiny group of people that wouldn't want to know. And I think it gets even tinier because you can bracket, I want to bracket individuals for whom clinical action wouldn't be indicated. So people with a terminal illness, people who are the elderly, people with religious objections to receiving medical treatment. These are people for whom the information is not actually actionable because they wouldn't take action. So let's bracket them. I'll talk a little bit more about them in a second, but so I think it's a really tiny group of people who wouldn't want this information. So the second question, now we've established as a tiny group of people, what sort of harm would they experience? I'm going to go through this pretty quickly because it's fairly detailed, but I think you can think about psychological harms and economic harms. Psychological harms, the idea of stigma, discrimination, anxiety. And here, the issue, there's this effective forecasting literature. We are terrible as a species at predicting how we're going to feel about our future affective states, whether or not we're going to be happy or sad about something in the future. We are terrible. We catastrophize. We think we're going to be much more unhappy than we actually are because we undersell our ability to cope and to adjust to future events. So the paradigmatic example is someone who's in a car accident and is paraplegic, quadriplegic. If you ask them right after the accident how they're going to feel in 6 months, they're going to say, terrible. I'm going to be so depressed. My life's not going to be worth living. But then if you go back to them in 6 months, they've actually come back up to a level of happiness that's pretty close to their baseline that they had before the accident. The same is true of positive events, so like lottery winners. The curve goes in the opposite direction. They think they're going to be super happy forever, but they come back down to sort of the baseline level. We have our baseline level of happiness. It might differ for each person, but we're pretty, sort of an anchor. We always come back to that. So we're terrible at predicting how we're going to feel about things. And the worry is that because of that society is systematically overestimating the durability and intensity of the effective impact of evidence on well-being, resulting in a culture of risk aversion in which patients are opting out of potentially beneficial diagnostic and treatment regimes because they're worried about how they're going to feel when, in actuality, their response to negative genetic information is going to be transient and mild, or at least that's what the evidence thus far says. Discrimination, economic harms, that's the other worry that people cite as a reason why people wouldn't want to know things. I'm going to go through this quickly, but basically, evidence suggests that the fear of discrimination is certainly very real. People are very worried about that, but actual cases are really hard to find. The Genetic Information Non-Discrimination Act it's a national law, it has a tiny number of cases with a minuscule judgment amounts. There are some more cases in other insurance contexts, but really someone did a systematic survey, and with the exception of Huntington's disease, there's really no evidence of systematic discrimination happening. There are isolated cases, but no evidence of sort of widespread that would yield a highly negative societal impact. So I'm not saying that genetic discrimination will never be a problem, but my argument is we should make a clear-eyed assessment of the frequency and magnitude of any economic harms flowing from disclosure of genetic risk information before automatically assuming a worst-case scenario when we're building policies about the right not to know. Okay, so tiny group of people wouldn't want to know. I've argued that the harms to them, the psychological and economic harms to them, are actually really small, and there's not a ton of evidence of serious harms. And then the last question is, if you ask people, if you actively solicit preferences, are you going to get people that accidentally or erroneously check the wrong box? And I think there are a lot of challenges in ascertaining preferences. There's lots of evidence that people are terrible about engaging with and understanding consent forms. I mean, this is an aside, if we actually took this literature seriously, I think I would worry about whether anyone is giving adequate informed consent. But there have been particular concerns about the complexity of genomic information, It's really hard. Lots of smart people have tried to figure out how to describe the huge range of types of genetic information in a way that people can understand, and we still haven't figured out a good way to do that. And it's really hard because you ask someone reads a consent form, you're asking them to make a really monumental decision at one point in time when, you know, their preferences could change over time. You might not do the analysis for 5 years, and something that a 25-year-old unmarried person says might be different than a 40-year-old with 2 kids or a 60-year-old who's approaching retirement. I mean, preferences change over time, but you're asking them to check a box once, and that's their answer. Unless, of course, they go back and change it, but who's going to do that? So I have an extended argument in my paper, but I'm really skeptical about our capacity to adequately and accurately assess individual preferences about knowing or not knowing specific categories of information. I think we're going to get the answer wrong quite a bit of the time. I question the validity of automatically privileging broad hypothetical checkbox answers. And I think there's a very real risk that actively soliciting preferences about right not to know could result in people making choices that don't actually reflect their true values and preferences. So, very small group of people who don't want to know, risk of harm is minimal, as I've argued, and there's a risk that actively soliciting preferences could result in people making choices that don't reflect their actual views. 2 more things: moral distress. This is the idea, I call it I can't sleep at night problem. A situation where one knows the morally correct action but is constrained from taking it. So doctors, nurses, they know what they're supposed to do vis-a-vis a specific patient, but because of legal restrictions or policy or whatever, they can't do it. And so I'm not arguing that this is determinative, but you know, the moral views of providers and researchers are relevant here, and if they feel an obligation to return certain kinds of information, that's at least another little weight in favor against a strong right not to know. And the last small point is genetic exceptionalism. There have been quite a few people who argued we shouldn't treat genetic information differently than all other kinds of information. And proponents of the right not to know are basically arguing that we should treat genetic information differently. If you broke a rib and went in to get a scan of your broken rib and the scan revealed a tumor, your doctor's not gonna say, oh, would you like to know? We found something, would you like to know about it? They're just gonna tell you. And so the analogy between that sort of imaging finding and genetics findings isn't perfect, but to the extent it's pretty close, why are we treating genetic information differently? Since it's standard practice in a lot of medical situations to disclose non-genomic findings, it seems fair to ask whether this instance of genetic exceptionalism is warranted. And I think that given the thorough rejection of genetic exceptionalism, the burden of proof should lie on right not to know proponents to make that case, which they haven't really. So let me conclude. I've argued that the costs of imposing a strong right not to know policy of actively soliciting preferences, that there are potential costs, and the harm is relatively low. And so I think it argues in favor, against a strong right not to know. Now, you might, as I said earlier, you might disagree with my analysis of the existing data, but I think you need to use this framework if you're making an argument. You need to look at both the harms of imposing information and the costs of a strong right not to know. I've argued that the prevailing autonomy-based view of a strong right not to know is philosophically shaky, it's legally questionable. I think popular opinion is going to be shifting, and I think the strong right not to know would do more harm than good. But when we come down to it, I can't endorse a pure beneficence view. I'm not saying we should tie people down and force information on them when they're actively resisting that knowledge. I think I would lose my bioethics card if I did that. Sort of So autonomy is no good, I've argued. The pure beneficence view, I don't think I can bite the bullet there. Somewhere in the middle is this idea of libertarian paternalism, the nudge idea, that you still give people a choice, but you sort of give them a default option that pushes them in a particular direction. And I think this is a pretty good answer, except, remember, I'm fairly skeptical about whether or not we can accurately capture people's views. And so my view probably falls somewhere between libertarian paternalism and beneficence. And I've argued that for high impact genetic information, we shouldn't solicit preferences. We shouldn't ask the question. We tell people there's a default set of high impact information that will be looked for and returned. And in the rare cases, which I think will be very rare, where someone says, well, I'm not sure I want to learn that, then beforehand you have a conversation with them. If they insist, then they insist. But it's not this sort of checkbox yes, no thing that takes 5 seconds in the course of a whole huge informed consent process. And I think at the end of the day, most autonomous adults would want to know life-saving information. The few that we can predict might not. I think they are easily identifiable, and so we should treat them differently. We can have a different procedure for them. If you've got a terminally ill patient and you're sequencing their genome to maybe treat their cancer, sure, ask them whether or not they want to know incidental results, because they're a different case. But I don't think they should drive policy for everyone. I think we should treat them differently. And bracketing the question of whether or not a right not to know exists in any circumstances, I think we should at least stop talking about it in such absolute terms. For high impact information, I think any deviation from regular disclosure should be a clearly defined exception rather than the basis for a broadly applied conception of the right not to know. And I think that as a field, as medical professionals, we should at least question the idea that psychosocial concern should automatically get to trump a prospect of life-saving interventions. So thank you. I'm happy to take any questions.